Hello, this is the Dental Protection Podcast. My name is Dr. Alistair McKelvey, and this is the Spotlight on South Africa series. Now, in today's podcast, we're going to be talking about all things about consent. And joining me for this discussion, we once more have Dr. Cobus Barnard. And for the very first time, we have our legal expert, Dr. Yash Naidu, from our Pretoria office, from MPS SAS, that's South African Services in Pretoria. Yash is a case manager there, but he's also been an attorney and a dentist, so he's very well qualified to tell us about consent. So, Yash, welcome to the podcast. Let's get the conversation underway. And again, Cobus, I'm coming back to you because I think you probably pick up a lot of issues in patient complaints around consent, and it'll be things that people don't do properly, or it'll be things that they forget to do. But maybe if you can just tell us from your experience, what are some of the key things that go wrong with the consent process?
Yeah, thanks, Alistair. So what I see is dentists not talking to their patients about their expectations, why they came to visit the dentist that day, about the treatment options and how much it needs it's going to cost the patient. You know, dentists are proceduralists. We fix things by nature. We program to solve a problem in the short time that we have available. And we sometimes forget to have the necessary discussions with our patients that needs to go with the treatment.
Do you think that's because they just don't schedule in enough time in the appointment, or they're maybe just not good at communicating with their patients, or are we back to sort of almost like a form of paternalism that I'll tell the patient what they need, and provided they nod and their mouth opens, then we'll get on with it? I mean, is that how poorly consent works in some cases, or are we a lot better than that? And it's just that there's not an awful lot of evidence written down from the consent process.
You know, Alistair, we come out of that whatever you say doc area where dentists, where patients just believed everything we said. But that has changed, you know, with the availability of information and the internet, and people are becoming more health conscious. And as you know, patient autonomy are now probably the most important cornerstone of the whole consent process. So, yes, so that's, for me, a lot of the dentists will blame that they don't have time to do that. But for me, what I see is more dentists not willing or not able to communicate with their patients.
Yeah, I probably agree with you almost completely on that. Occasionally I see consent forms being used, okay? And it's a very generic consent form. And this is where I want to bring Yash in, because we need to understand that consent is not generic. It's very specific for the intervention, or certainly for the diagnosis and the options available and the intervention chosen. So a lot of dentists still rely on generic consent forms. But Yash, I'm kind of hoping that you're going to tell us why a generic consent form is not really that useful.
Thanks for having me, Alistair. It's good to be on here with you, and good to be here with you, Cobus, also. Alistair, I want to start at the basic principles here first, and then expand on your question, because, you know, in order for me to get to the nub of the question, I have to go back. You know, it's all very well that we have HPCSA guidelines, which are in some respects authoritative and perhaps persuasive to a court. But at the end of the day, if we as practitioners find ourselves in court and the argument by the patient is that we didn't get proper informed consent from our patient to provide the treatment, what we'll be judged against is actually what the law says about informed consent. And gents, please, I know you're both clinicians at heart here. And I'm doing the typical lawyer thing by going into and quoting the law, but bear with me because I must touch on these aspects before I expand. So what is the law that actually says to us, this is what you need in terms of informed consent? It's the National Health Act, right? And it's echoed in the HPCSA's guidance on informed consent. So the HPCSA, unsurprisingly tends to agree with what the National Act says. And this is what the Act says. It says that informed consent means consent for the provision of a specific health service by a patient who's informed as follows. And it says a couple of things, but I'm just highlighting the absolute essentials. So the first thing it says is that the patient must be informed about the range of diagnostic procedures and treatment options generally available to the patient. So not even specifically, but generally in relation to their issue. The second thing that it says is that the patient must be told the benefits, risks, and costs and consequences associated with each option. And then lastly, the patient must also be told that you have a right to refuse what I'm suggesting as a practitioner, but these are your risks, these are the potential implications, these are your obligations associated with that refusal. So that's what the law tells us we need to tell our patients in order to get their informed consent. And if we haven't done those three basic things, we're essentially not following the law. So what does that look like? Now, this is going back to your question, right? It's not just a form that you hand to the patient and say, sign. Here we go, have a read and sign. It's a discussion. It's something where you use verbal and non-verbal cues. Our colleague, Dr. Raj Ratan, who's a dental director there at Dental Protection, he's written a brilliant article just specifically on this point. And it's that, when you're having a discussion with a patient, Alistair and Clovis, you can pick up sometimes, you'll see a blank expression on their face. Now, that is something that you can't record in the record, in the patient's file, but you will have to detect and say, look, in your mind, I can see that this is going over the patient's head here. And you pause and you say to the patient, I think I might have lost you. Have I not explained something carefully? And do you need me to repeat this? Do you have any questions for me? You don't simply just speak at them, and once you've had the discussion, you move on. No, you say, look, can I explain something? So it's a proper conversation. You need to make sure the patient's understood everything, and then only after you've done all of that, then do you go and document it. Because the documenting of the discussion, in my mind, and I think in the HPCSA's mind also, is less of an important thing than actually having that discussion. All that the document or that generic form that you were referring to, all that does, Alistair, in essence, is provide us with some documentary evidence that a discussion happened. And remember, again, another brilliant article by Raj, that discussion that I'm documenting as the practitioner, that's my version of it. I might have had a discussion where I've explained all of these things that the National Health Act requires me to explain. And I go into the file and I say, informed consent discussion had, consent obtained. That's not expanding, but at least it shows that I've had the discussion. Similarly, another colleague might just have a 2-line conversation with the patient, still write the exact same thing in the records, but the actual important conversation didn't happen. So, informed consent is something that is very important, and it's more of not a monologue, it's more of a conversation, it's ongoing, it's not static, and it carries on. Now, Alistair, I knew we were going to be talking about this topic, and in preparation, I thought, let me try something a bit different here, just to see what would happen. Now, there's this buzzword going around, artificial intelligence, ChatGPT. And so I went onto this ChatGPT, and I wanted to see whether AI or artificial intelligence would answer or have an informed consent discussion better than I did when I was in clinical practice. And so I gave it the following question, and I promise you, I gave it one chance, and this is what I wrote. I'm going to read it verbatim, and I'm going to tell you exactly what it said to me. So let me find my screenshot, because I have screenshotted it. So I said to it this. I said, assume that you are my dentist and I'm your patient. You are going to recommend root canal treatment to me. In that context, give me the range of treatment options available to me, the benefits, risks, costs, and consequences generally associated with each option, and explain to me my right to refuse the root canal, and explain the implications, risks, and obligations associated with the referral. So I'm stopping. That's where I asked the question. That's where I stopped. typed it in, and I pressed enter, right? And immediately this artificial intelligence, so not real intelligence like me or you or Cobus, or some would argue I don't have even artificial intelligence, but this is the answer it said. It said to me, and here again I'm going to read, and I'll tell you when I stop reading. We can always cut this out later if it's too long. So the artificial intelligence told me this. As your dentist, I would recommend root canal to you based on my assessment of your dental health. Root canal treatment is a common dental procedure used to treat dental infections, decay, or damage to the dental pulp, which is the innermost part of the tooth that contains the nerves and the blood vessels. The range of treatment options available to you will depend on the severity of your dental condition. If the damage is minor, we may be able to treat it with a filling or a crown. However, if the damage is more extensive, root canal treatment may be necessary. The benefits include, and it goes on to, I promise you, it speaks about, it says preserving the tooth, eliminating pain and discomfort, improving oral health. It then talks about the risks. It says there's infection, tooth damage, discomfort. The costs can vary depending on your location and your insurance coverage. Your insurance may cover part or all of the procedure. If you choose to refuse the root canal treatment, there may be consequences associated with that decision. In some cases, the infection or damage may worsen over time, leading to more extensive dental work or even tooth loss. Refusing treatment can also lead to ongoing pain and discomfort. And here's the part that impressed me with this artificial intelligence. It says, ultimately, the decision to proceed with root canal treatment or not is yours to make, and I will support your decision while also giving you all the information needed to make an informed choice on your dental health. So if artificial intelligence can do a rudimentary good discussion, I think we should all hold ourselves to at least that standard, Alistair. And I hope I've answered your question.
Yeah, I mean, that was brilliant. Yeah, it's quite interesting there, because what I was hoping was that you were not suggesting that everybody use artificial intelligence for to take over the conversation. But interestingly, I was waiting for you to tell me that the artificial intelligence also warned you about the risk of endodontic file fracture, because that's one of the major problems that we see in South Africa. I mean, there's not a week goes by that there's not a request, please would you help me with this complaint? I fractured an endodontic instrument and the tooth couldn't get it out. Gave the patient the options. They're now being referred to a clinician with a practice limited to endodontics. We can't call endodontist specialists because there's not a specialty yet around endodontics. But the idea is to send the patient to somebody who has the microscope, then the experience and the equipment to get the file out. And then, but the sort of the elephant in the room is, and who pays for this? Okay. And that's the problem. And by the time you say to the patient, well, look, this is a recognized non-negligent complication of the treatment, it's too late. You have, if it's a recognized complication of the treatment, the patient needs to know that before they agree to go ahead with it in the first place. And if you do have that conversation about the risk of file fracture and the fact that if it happens, it's an accident, it's nobody's fault, and it's the patient must pay for the recovery of the file and the completion of the root canal. And if you talk about this before it actually happens, it's much easier to deal with than afterwards when everything else feels like an excuse. So I'm glad you've kind of, yes, there's a lot of artificial intelligence out there. I'm hearing a little bit of, well, there's an awful lot to have a conversation about. We're saying the conversation is the key thing. What about recording the conversation, Yash? What about what happens to the recording? Does that become part of the treatment record? Do we have to retain that for a minimum of 6 years from the last treatment visit? And do you think we are far enough along the creation of software that can listen and turn it into a record? What would you say if a dentist said, look, I've heard all this, Yash, I know we've got the artificial intelligence, we're not all going to use this, but could we just record the conversation? And what do we do with the recording? Is it part of the record? What do you say to that?
Well, look, in an ideal world where, let's just say, we had the most sophisticated technology available, I'd say there's no problem with recording a conversation. But you need to bear in mind that a recording of any conversation regarding a patient's health is their special personal information. In the UK, you guys call it special category data. And it needs to be treated with the utmost care and in line with either GDPR or POPI provisions. You keep it in the file, you keep it on the electronic file, you need to make sure that there's security measures in place to avoid any unauthorized access, etc. In a nutshell, yes. But if not, and if you're using the more conventional versions of recording, it's sufficient to write that you've had the discussion, you've explained various pros and cons, etc. You don't even have to get into too much detail. The important thing is that you've had the actual conversation, the patient has accepted it, understood it, and is able to make an informed choice.
Brilliant, Yash. Thank you. Cobus, you've been quiet for too long here, so I'm going to bring you in here because this is the bit I just don't get. We've heard from Yash that the consent process is about this exchange of information, and when it works well, it's beautiful, and you tell the patient what treatment options there are, and you tell them what the approximate cost. So it's a cost estimate. So you're giving them an estimate of what the treatment costs. And there should be no more problems, but we just see so many complaints. And I bet you deal with loads and loads of complaints about patients who are presented with an account that they didn't know they were going to have to pay. Now, I may be oversimplifying things, but I think that we're almost capable of creating our own problems here around informed consent and telling patients what benefits are available. But from with my clinician's hat on, I'm thinking, right, I'm going to tell the patient that, okay, you're having this crown done, it's going to cost you 20,000 Rand, and that's what you will pay for that crown. Now, when I mean that's what you will pay for that crown, that's what needs to be paid. It doesn't matter to me where the 20,000 Rand comes from. But we see so many situations where patients have treatment in South Africa thinking that treatment is covered by their medical aid. And when it's not, because their day-to-day savings have been used up with visits to optometrists or GPs or something, there is now a bill that they didn't expect to have to pay. And you often see them running this argument, oh, if I knew I had to make this co-payment, I would never have, I'd have just had my tooth taken out. So is this what you are seeing? And are we ourselves making it more complex than it needs to be around discussions about who pays and where the medical aids fit in here?
Yes, thanks, Alistair. Yeah, so a lot of the complaints we deal with is some sort of misunderstanding about who would pay for the treatment when there's third parties involved, like medical aids. You know, and the big question is always, would the patient have proceeded with the treatment if he or she knew that they're going to have to swipe their credit card, you know, because there's confusion about who's responsible for checking the benefits and doing the necessary pre-authorization procedures. You know, and dentists make it more complicated when what it actually is, like you said, because the financial consent process is a clear process where you inform the patient how much the procedure is going to cost, regardless of whether the patient have a medical aid and who will pay for the treatment, the patient or the medical aid. So, so like you say, the profession bring it amongst themselves. They kind of create this confusion because patients are often being misled by the administration team at the practice that inform them that their crown has been authorized and the medical aid will pay for the treatment. But then the patient's wife goes to the optician and claims a pair of new glasses that comes out of the same pool of funds. And by the time the crown needs to be paid, there's no money left. And that always creates confusion and a dispute because the dentist wants his money and the patients say that they wouldn't have proceeded with the treatment if they knew they're going to have to pay for it.
So is there anything that you can recommend we do better or do less of or do more of to get round this problem? Because I think as a patient, they turn up at the dental practice and they expect the dental practice to tell them what benefits are available on their plan, and if there is going to be a co-payment. And if you say, no, there's not going to be a co-payment, I charge medical aid rates, and then all of a sudden there's a shortfall and the patient has to pay out of their own, with their own credit card, then there always seems to be a problem. I mean, how can we get round this? Is there a magic wand to solve this?
You know, Alistair, like you said, we overcomplicate it. It's as simple as giving the patient a treatment estimate and letting them sign it, or even just send an email where you inform the patient how much the treatment's going to cost. And by replying to the email, the patient accepts the treatment plan and the costs involved. And that's it. That's enough to show that you've got financial consent and that you've discussed the fees with your patient. And this is the first thing the HPCSA or SADA would be interested in. If there is a dispute about fees, is show me evidence that there was a discussion of fees, you know?
And Alistair, can I just jump in on one point there? Which I had alluded to earlier, and the HPCSA actually specifically mentions it in their guidelines. We all know that treatment is a dynamic process, and sometimes things will change from one appointment to the next, which might necessitate more treatment or less or whatever. As soon as you pick that up as a practitioner, it's incumbent on you to bring it to the patient's attention, explain to them the consequences of any alterations in treatment, provide them with another estimate and let them know. You know, don't always rely on the initial cost estimate, because that's a dynamic issue. Treatment is dynamic and can always change. You know, in most cases it won't, but if that happens, and that's when we see a lot of disputes coming up.
Okay, guys. That's brilliant. I mean, this sort of neatly brings us to the end of today's podcast, and I hope there's just one or two things that are a little bit clearer from our discussion today. If you'd like a certificate for listening to go towards your CPD or learn more about what we covered today and who you were listening to, please do take a look in the podcast description. My name's Alistair McKelvey. I've been your host today. Thank you to Cobus and for Yash for your inputs, and thank you all for listening.